All right, good evening. It's really a pleasure to be here. So basically my talk is really going to focus on two things. iTrace for the individual, but from my point of view, much more interestingly, iTrace and big data. I have no conflicts of interest. In big picture, I practice at the Mayo Clinic in Rochester, Minnesota. We've had the iTrace for about 3 years. We've done about 30,000 iTrace exam components, so wavefront or corneal topography measurements in about 5,000 patients. I personally mainly do cataract surgery. I get the iTrace on every patient pre-op, post-op, and then every patient sent in for, quote, trouble after cataract surgery. So in my point of view, the utility for individual clinical scenarios is really well established. And I'm just going to quickly run through some scenarios in the context of a normal cataract surgery practice to give you a flavor for how we use this. So first patient's a younger patient who presented for bilateral cataract surgery. Patient has width to rule astigmatism, and just for the sake of time, I'm going to go through this pretty quickly. So cornea-wise, you can see the regular astigmatism. You see kind of the mix of aberrations in the internal optics and the simulated vision potential with lower order aberrations corrected. So total eye aberrations, internal optics significant, cornea has good vision potential. We put in a toric IOL. These are the post-op results, and you basically see the regular astigmatism of the cornea, regular in the lens, total aberrations, minimal in the eye, with final refraction close to plane on a very happy patient. So basically, and that's a simulated vision post-op. The left eye is essentially the same thing. With the rule astigmatism pre-op, we do the same thing, put in a toric IOL, and these are the post-op results. Cornea regular astigmatism in the IOL, but astigmatism in the total eye. So this is what's amazing. Before the patient ended up in my chair post-op, you get the toric calculator, the screen where you can look at toricity and the internal optics, and you see the corneal astigmatism, the right magnitude of astigmatism from an internal optic point of view. But this axis here, it's not 90 degrees off from the axis in the cornea. So right away we know we have a toric IOL that's in the wrong orientation. Very quick insights with minimal digging having to be done to get where you need to be. Another scenario here that's pretty interesting is in the context of limbal relaxing incisions. These are really based on nomograms and large populations of patients. What oftentimes is missing is the individual feedback from the individual cut you do and the effects that it basically has. So this is a patient, this is the post-op iTrace, but I'll just tell you what we did is I did limbal relaxing incisions in the left eye. This inferior nasal limbal relaxing incision was in a normal location. The superior temporal one, because of the location of the paracentesis port, I had to make it more peripheral and closer to the limbus. So post-op, I was curious, did that even matter or not? And amazingly, the patient had both high astigmatism pre-op, and you could very clearly see after the fact that the LRI in the right location had a pretty good effect. The one that was too peripheral almost had no effect at all. So we got that individual feedback regarding what we were doing, again, without much work ahead of time. You really get good situational awareness here. This is a patient this week who literally got sent in from the optometrist saying, your only problem is cataracts, you need to have cataract surgery, and you're going to be really happy afterwards. So they come to clinic with this predisposition, and before they show up in my chair, I know that there's going to be an issue because this is their iTrace ahead of time. So you see basically, massive amount of aberrations with a fairly normal pupil size, internal optics, but the cornea looks terrible. They actually have keratoconus right out of the chute. And with this patient in particular, there's an issue because they showed up really under the impression that they were going to be happy after cataract surgery. And when I tried to explain to them, well, you may not be so happy after cataract surgery because your cornea vision potential here, they didn't really know who to believe. Is it me to believe, the other person to believe? But then when you can show them this picture with kind of simulated vision potential related to the cornea and then explain how potentially a hard contact lens would fix this, it's a lot easier to get on the same page ahead of time, I think, when you have this good educational tool. And then there's always the very challenging situation, why can't I see better after cataract surgery? So this is a patient referred in where basically not happy with their vision after cataract surgery, and what you see basically based on the topography and with a relatively small pupil size, the corneal irregularities, including the coma, suggest there's issues which was previously basically unreported refractive surgery that nobody thought that they really needed to mention, but that was really an issue there. So you can get a lot of information without having to dig deep. The abundance of clinical data, though, really begs the question, can we go beyond the individual patient? Is iTrace ready for big data analytics? And to find out, basically, we need to get the raw data. So if you're interested in doing this yourself, you can do what I did this last weekend. And when you go to your main software screen, if you go to the settings button, the second box from the upper right, you can't read it well here, it says Excel export with a settings button. And you can basically get 3 different spreadsheets back. You can make a spreadsheet of all your corneal topography type measurements. You can get a spreadsheet of all the wavefront measurements. And then you can get a combined spreadsheet for all the wavefront and corneal topography measurements that the machine is associated with each other. And by associating these, then you get the derived information. So the internal optics you get, and then you also get the dysfunctional lens index. So basically, I would advise you, if you're going to try to play with the export, pick all the fields. It's much easier to get all the data and hone down with what you want after the fact than go and redo the export multiple times. I learned this the hard way. You go back to the main screen, select the patients you want, hit the export button, and you'll get something that looks like this. For example, for that combined spreadsheet, you're going to get an Excel file, or at least I did, that has over 700 data fields in it. So this can be a little bit overwhelming in the context of manual data analysis, but from a big data analysis, this really isn't so bad. But you have to know what to do with this. So when we did our big data analysis, what we do is you use Microsoft Excel for the spreadsheets, but there's a Power Pivot and a Power BI package with Microsoft that if you take the time to learn how to use this, makes it very easy to look at and manipulate big data. And then we used RStudio for statistical analysis and basically the graphing, and all this was done in the last week. So from a time intensiveness point of view, this is doable if you take the time to learn these tools. We took the next step though, and we basically made a spreadsheet exporting our cataract surgery dates, eye, and whether or not a limbal relaxing incision was done at the time of cataract surgery from our clinical database, and related this to the iTrace data. And so we used a simple algorithm to basically then flag in this iTrace export which one of those exams were done pre-cataract surgery, which ones were done post-cataract surgery. And so then we could basically get more granular analysis of the iTrace data we have. So big picture, what do we have? So the demographics, so here's patient age, number of patients. So we have a high N here. Basically, if you look at the age parameters of this patient population that we have these iTrace measurements on, it's kind of predominantly in the United States a Medicare cataract surgery patient with other adult patients and very few younger patients. Well, how about something more interesting? What if we take all this data and try to determine what's the distribution of the magnitude of corneal astigmatism and corneal spherical aberrations across our patient population? The question is, are these typical? By looking at this, does this lend credibility to what we've done from kind of a data packaging point of view, or is there something not right here? So if you look at corneal astigmatism, so this is diopters at the bottom, number of patients here, and you see basically the majority of our patients have less than 1 diopter of astigmatism, the huge majority less than 2 diopters, and the bell-shaped curve has basically a long tail to the right like we would expect for astigmatism distribution. So this looks reasonable. What about corneal spherical aberrations? Again, very high N. If you look here, 0 for spherical aberrations. This bell curve for corneal spherical aberrations at 6 millimeters is centered kind of in the 0.2 something micron range, which is kind of what we know or expect from data that we have from aspheric IOL studies. So this actually looks pretty reasonable, that our database is a reasonable proxy for a cataract surgery population. Okay, so then the question is, if we have a reasonable database, what can we do that's more focused and more clinically meaningful? So I put it in the form of a few questions. So now shift your brain to angles. Angle kappa, so just as a refresher, angle kappa is the difference from an angle and magnitude point of view of the center of the pupil versus the center of the visual axis. We kind of generally understand that pupil tends to be temporally displaced from the visual axis, but the question is, do our data on a big scale confirm or basically refute this? So let me orient you to this plot. Think of this as looking at a corneal topography. So this is a polar plot, 0 degrees, 90 degrees, 180 degrees, and 270 degrees. Each little spot there is the center of the iTrace measured pupil relative to the visual axis center, which is in the middle, and then each ring is half a millimeter from a distance point of view. Green is left eye, red is right eye. So basically the center of the left pupils are temporal to the visual axis, the center of the right pupils are temporal to the visual axis. You can see the distribution of these pupil centers, but this whole thing kind of makes sense in terms of what we know. And the N here is huge. We have 15,000 exams here. So So what about pupil size? We have this measurement of kind of a scotopic pupil size that we get from doing the iTrace, and the question is, what does this show? Nobody really does big studies of pupil size because it's too laborious to do that sort of thing. So this is a graph of patient age, pupil size, and diameter, and it's hard to see here from a kind of sharpness point of view. That's 5 millimeters, 10 millimeters, and 2.5 millimeters from a scale point of view. This is broken down by gender. Red is female, green is male. So basically, you see, first of all, big picture general trend. The scotopic pupil size generally goes down from young adulthood to this is kind of 80s and 90 years old. And it doesn't look like much on this graph, but kind of the mean. So the line is the mean, and the gray is a 95% confidence interval. The mean for the pupil size goes from 6 millimeters down to 4 millimeters in more elderly folks. That's a 50% decline. Now, in general, when we think about things going down, we think that's bad, right? Well, it's bad if you're the cataract surgeon, but if you get through the cataract surgery, the reality is if iTrace has taught me anything from looking at all these exams, the huge majority of my patients and myself would actually probably do better from a visual quality point of view and live life better with a small pupil versus a large pupil. So this actually may be one of the few things that gets better with aging from this data. And then basically, anytime you see a white space between the two lines, that suggests that there's a statistically significant difference between these numbers. So for most of adulthood, basically, the female population may have a little bit larger pupil size than the males. Although it's a statistically significant difference, this is like 0.2, 0.3 millimeters. It may not be clinically significant, but that's what the data show. All right, switch back to angles. Now, angle alpha, and this really pertains more to cataract surgery. So what's angle alpha? Because it's really easy to get confused with all these angles. Angle alpha represents the orientation and magnitude of the difference between the visual axis and the center of the IOL. Well, we don't really measure the center of the IOL. The iTrace measures the center kind of the cornea, limbus to limbus, and uses that as a proxy for the center of the IOL. If you accept that that's correct or accurate, then the question is the orientation of this angle alpha and potential IOL decentration relative to the visual axis, is this evenly distributed across all clock hours, or is there a preference? Any thoughts or ideas? I certainly didn't know. Here's the answer, and it's amazing. So this is orientation in degrees, and we just rounded it to the nearest 10 degrees. So basically, center around 0 in the high 300s, that's a horizontal axis. Around 180 is a horizontal axis. The vertical axes are here at 90 and 270, and look, the angle alphas actually seem to be mainly distributed across the horizontal axis. Okay, what about magnitude of angle alpha? So there's stuff out here, and for example, this is a website from a more prominent cataract surgeon in the United States. In their guidance to the referring optometrist says is if the magnitude of angle alpha is greater than 300 microns, you shouldn't use a multifocal IOL. Other people kind of do similar things and use 0.5 as a cutoff, or 500 microns. So the question we had is, if you're going to start to establish kind of cutoffs or criteria for the magnitude of angle alpha, how much will this affect your multifocal IOL kind of candidate patient population? Does it have a big effect, or is it so small you really don't need to think about it or worry about it? So here's the answer. So this is a density distribution, so angle alpha from 0 to 1 millimeter. And basically the density distribution is if angle alpha were uniformly distributed across these basically different magnitudes, you would see a rectangle. It would go straight up, across, and back down, but it's not uniformly distributed. The majority of patients have an angle alpha it's overrepresented between a magnitude of about 0.2 something millimeters up to 0.6 millimeters. So then back to the question. If you use 0.3 as a cutoff for multifocal IOL eligibility in our patient population, only 20% of your patients become eligible. You exclude 80% of your patients. If you move your cutoff up to 0.5, then 70% become eligible, and about 29 or 30% become ineligible. So I don't have the answer for where angle alpha matters, but it's a very significant decision in terms of the distribution in our patients. Okay, question number 5. There's this dysfunctional lens index. This has come out from iTrace, but the reality is how do you know if this thing's accurate? How do you validate this? It's a number, and we tend to anchor towards numbers. I don't know how many, I'm sure it happens to you all, how many of my patients say, give me a number for my cataract. And I say, well, I don't really have a number for your cataract, but they want it. And we tend to kind of overweight the relevance of this number, but the question is it reasonable to do it with this one? So let me show you what we have. So this is patient age at the bottom. This is the reported dysfunctional lens index from the iTrace. We have basically subset our patients into 3 groups. Let's start with the red. The red group is patients we did the iTrace on, but they never ended up having cataract surgery. So this is the mean dysfunctional lens index and a 95% confidence interval for the mean. So what happens is basically what you see is, first thing is, the thing makes sense in the context that younger patients in general have a higher dysfunctional lens index than lower ones. It kind of gradually goes down over time. Like, that seems reasonable. All right, blue. This is pre-cataract surgery. So this is patients we knew ended up having cataract surgery by us, and this is what their dysfunctional lens index measurement was before we did cataract surgery. And you kind of see the blue here, and the blue is a lower number than the patients who didn't end up having cataract surgery. That seems reasonable too. And then of course the third question is, what about patients after cataract surgery? And that's the ones in green. And their dysfunctional lens index basically goes back to kind of the range of the people who basically didn't have cataract surgery, and it basically goes up to a higher number relative to those who are pre-op. So when you look at the numbers kind of big picture intuitively, at least with the end that we have here, the DLI, it kind of makes sense. It seems reasonable. Okay, last question. Can we use this data to kind of study or perform quality control on our refractive outcomes after cataract surgery? Something that everybody's interested in doing, but it's so laborious to try to get the data all in one place to kind of do these sorts of analyses. And the answer is yes, we can. Let me show you what we have. Okay, so this is a box plot, and I'll tell you what the box plot is. So here is spherical equivalent diopters. These are patients we have the iTrace on that never ended up having cataract surgery. So it's just a spherical equivalent, the refraction. The box plot is such that basically 25% to 75% of the patients had a spherical equivalent in the range of this box. 95% of the patients go to kind of the tails of the whisker. The horizontal line is the median, and the notch in the line represents a 95% confidence interval estimate for that median. So what you see is basically in the patients in general, about 3/4 have a myopic spherical equivalent, about 1/4 are hyperopic, with a pretty big distribution. Now jump over to this box here. This is the pre-cataract surgery spherical equivalent for the patients who ended up having cataract surgery. And what do you see? You kind of see a pretty big distribution in terms of those numbers. And what you see is the median is actually more myopic than those who didn't have cataract surgery, which again is intuitively what we know in terms of myopic shift and cataracts being worse. And then what do we really care about? We care about our post-op results. So here's our post-op results at the clinic. So here the median kind of spherical equivalent post-op is 0.12. That's a pretty reasonable number. And the distribution is basically very tight around that. So basically those outcomes are pretty reasonable, I think, and they're where we want them to be. And you see the massive, basically, contraction of the spread in spherical equivalents from no cataract surgery, pre-op cataract surgery, to post-op surgery. Okay, and then finally, what about astigmatism? So these are all patients who've had cataract surgery. This whole left plot is pre-op cataract surgery. Corneal astigmatism just in magnitude. So we broke them into 2 categories: the patients we didn't do limbal relaxing incisions on, the patients who got limbal relaxing incisions. And what we did is kind of appropriate. So those who got limbal relaxing incisions kind of had a median cylinder of about 1.5. Those who didn't have it had a median cylinder kind of in the 0.7 range. So it seems like our patient selection is reasonable. So what happened to them after surgery? So this is the no limbal relaxing incision patients. So basically their astigmatism post-op, it's almost the same as it was pre-op, and that's kind of what we'd expect. What about our LRI results? The post-op LRI patients, clearly we've contracted the median astigmatism from 1.5 down to about 1 cylinder with a little tighter distribution than before, but kind of you would hope that this number would be closer to this number, and it's not. So this is a bit of an issue. And if you think about it, the way we implemented LRIs in our practice is, like a lot of things we do, we are very conservative. We're conservative with our nomograms, we're conservative with our incision depth, and it is reasonable, and usually conservative is kind of a good thing. But I think we're probably over-conservative here, and this kind of would suggest that we have to look at our practice a little bit in terms of how we're doing this. So this is pretty good feedback or data. So to summarize, I know we went through a lot, but this is basically pilot big data work using the iTrace data export suggests there's really a high integrity with the data with patient age, pupil size, cylinder, cornea spherical aberrations. Very interestingly, with an N of 15,000, the undilated scotopic pupil size decreases with age. It decreases about 50% from young adults to older adults. And it may be a hair smaller basically in males versus females, which is intuitively correct, but not clinically of a large magnitude. We can kind of elegantly confirm that the angle kappa, or what we know about angle kappa, so deviation from pupil center to visual axis, puts the visual axis nasal or the pupil temporal to the visual axis, and that makes sense. Angle alpha deviation appears predominantly oriented across the horizontal meridian. Well, the question is, does this even matter and do we care? And the answer is, it may matter. So the question is, does angle alpha matter when you put in, for example, a strong toric IOL? If it matters, then if it's predominantly across the horizontal meridian, then intuitively that suggests that when you put in a with the rule toric, it may not matter that much. But when you put in it against the rule, it's a big deal. And so you have to think about it a little differently maybe in the context of that. So I don't have the answers, but that's something to think about. And then you have to decide where you sit in terms of angle alpha, the magnitude of angle alpha, and what kinds of lenses you're going to put in patients, because the decision matters. If you use a cutoff of 0.3, you're going to exclude 80% of patients. If you use a cutoff of 0.5, you're going to exclude basically 30% of patients. We're scratching the surface here. Potential software updates to the algorithms in basically iTrace software could actually make the quality of the big data export actually even quite a bit better than what we already have, which is pretty amazing. Big picture, I just want to say kind of on a personal, from using the iTrace over the last few years, it's a very powerful teaching tool, powerful for patients, but frankly, I've learned a ton just by looking at this on all the patients we see. I would encourage all, I think in my practice, certainly with myself, there's potential to be very intimidated by the wealth and complexity of this data, intimidated enough to where you kind of want to back away, but I'd really encourage one to dive into this, because I feel like we get a little wiser by doing this. It can actually be enjoyable, and I really think we're helping our patients in the process as we get a more granular understanding of what really is or isn't going on. And then finally, basically, if we can do more work in terms of programmatically relating the iTrace data to other data sets, which we just did a little bit of during the last week with what we did here, we can do self-service large-scale data analysis and get insights, frankly, that are almost unthinkable to our predecessors here. So I appreciate your time. I'd be happy to try to answer any questions you have. Yes?
As I understand that angle alpha, that is the white to white related to the visual axis done in a pre-op test. So it's not really the IOL, it's not really the IOL saturation. You're making an estimate of what theoretically would be.
Yeah, that's exactly right.
So with the multifocal lens, we can visually see where it is, assuming that the visual axis didn't change. Because at least we can see the multifocal center in the pupil. So it seems that, is there a way with the iTrace that you can tell the center of a multifocal lens with the little rings? Because if you could do that and correlate that to the visual axis, that would maybe be a more accurate way of determining the actual multifocal centration and how it relates to the visual axis pre-op.
I think that's a great question. The only way that I always try to think, how can you do it in an automated way? I don't think you can, where we can do that in an automated way. I think somebody took the time manually to X marks the spot on the image, on a post-op iTrace image, you could very easily make that determination and answer that question. Because what you say is very important. This is an estimation of what angle alpha may be, but we don't know if we're getting it right with that kind of corneal proxy measurement or not, but that's the best that we have basically pre-op and post-op, and if somebody were to do that, I think that would be a great contribution.
Great, just a quick follow-up to that. We did that a couple of times in the practice where we just manually centered circles on rings that were visible. I can't say that you'd be able to do that on all multifocal lenses, but we were able to do it and then manually, an angle, whatever you want to call it, the true angle out of the IOL versus the visual axis. I can't say that you can do it all the time, but it did work in a few instances for us.
Thank you.
The issue is, you're right, Mike, it's manual right now. And so we actually just had a discussion earlier about how to make it automated. And you're talking about big data analytics. And if it's manual, it's not going to be 30,000 iTrace exams. So that's the issue. So that's our challenge. We can do it manually, but it's more like when you have a problem patient, you can see his concentration more than what you were talking about.
Yeah, so I think it's clearly open for somebody to sit down with their patients and do 100 of these manually. I don't think we can do it in this way yet.
Question?
I'd like to ask a question. Do you think matching this data to patient questionnaires would be value? Pre-op, post-op, and diagnosis?
I mean, I certainly don't have exclusive rights on what good research ideas are, but to me it seems like a gold mine for things that you could do in terms of taking objective information and relating it to either clinical data or other subjective data. Absolute gold mine.
Folks, let's give him a hand. That was amazing.